Hi, I'm Matthew Hersberg. This is the Myopia Mindset, and it's time once again for Myopia News Monthly. This is our ongoing segment where we break down some of the top stories in the myopia management industry and just break them down for you. There's so much going on, there's always something new happening in myopia. Sometimes that can be a little bit intimidating. So, I brought on a panel of experts in order to help kind of digest it for you and talk about it because I always say, you should grow organically into the expert that you were always meant to be. Part of the way that you do that is by staying on top of what's happening in the news cycle. And joining me this week, as always, is my dear friend and regular co host for Myopia News Monthly, Dr. Andrew Brower from the Eye Care Center of DuPage. I love his practice philosophy. He says, I don't want you to wait forever to come see me, and I don't want you to feel like you're being rushed out the door. Andrew, welcome back to the show.
Always happy to be here. Nice to see you, Matt.
Same. And our special guest panelist is none other than Tony Summer. You know him from VTI, you know him from Cooper Vision, but recently he has been named the CEO of Treehouse Eyes. Tony, welcome back to the show.
Thank you very much, sir. It's a pleasure to be here.
Yeah, and Tony, this huge news in its own, you taking on the role of CEO. Like, I've been a big fan of what Matt Erding's done with the company so far, and of course Gary Gerber and everybody at Treehouse. I'm a huge fan of. When I saw the news come through that you were the new CEO, I was like, well, that just makes so much sense, and I'm excited to see what you're going to do with the company moving forward. And before we get rolling on the news cycle, I'm wondering if you can give us like a brief insight into like what you want to do with Treehouse. What can we expect moving forward into the future?
Well, I'm very much kind of a process guy. So when you think about the company itself, we've gone from being founder-led and figuring out what we are and repeatable process. And now my mandate is to grow the company, right? Go enter into growth stage in a meaningful way. And we do everything through the lens of helping give children better vision for life. Everything we do. And we do that in two different ways, and I'm reaffirming it. The first is we have thousands of children in treatment in just our 3 clinics, and we have really refined the entire process from start to finish of a successful myopia management practice. And so we get great joy every single day in helping patients and parents make the decision to enter treatment. The other part of our business is, well, we have this operating system on how to do it. So we coach, mentor, guide, and provide services for our partners who want to walk with us on their journey to a successful myopia management practice as well, because we can provide some shortcuts and some help along the way, and thus help expand our reach and help more kids have better vision for life. So that's what we do.
Yeah, I'm excited to see what happens next. I've scheduled Matt for an episode to learn from like 10 years of what we know so far from Treehouse, because you guys have some real actionable like data, like that. You've done research, you've got real crunchy numbers and whatnot to tell us about like what's happening in the industry. So I'm definitely excited to see what where you're going to take the company and see what happens next. So Tony, if anybody has any questions for you, wants to reach out to you and get in touch with you online, how can they do so?
Well, the first place you can always find me is on LinkedIn, and it's SOMMER. Second, you can always email me at tony.summer, and that's SOMMER @treehouseeyes.com.
Perfect. And Andrew, if anybody wants to get in touch with you online, how can they do so?
Sure. Straight through our practice email, c@eyecaredupage.com. So SEE at eyecaredupage.com.
That is awesome.
And
it's short and simple.
It's awesome.
And for my part, if you enjoy any part of this episode, consider becoming a subscriber on our Substack. We have weekly articles, we have bonus segments, we have a monthly mindset mailbag is what I'm calling it, a Q&A for our subscribers. Send us your questions and gain the benefit of Kerry Hersberg's 40 plus years of experience in myopia management. And let's roll right into the news stories. We're going to be covering 3 main stories in the main episode, and then we're going to be doing a 4th special story for our paying subscribers in our bonus segment. And that one you're really going to want to tune in for. So I'll tease that a little bit right now, and then we'll talk more about it later on. But Tony, I'm going to hand this one over to you after I read the abstract. So let's get rolling. This is from Helio. One of the biggest barriers to myopia management has always been cost, but that conversation may be starting to change. The American Medical Association has adopted a resolution supporting comprehensive insurance coverage and reimbursement for evidence based myopia treatments, while also backing efforts to formally classify myopia as a disease through the Centers for Medicare and Medical Services. The move recognizes progressive myopia as a growing public health concern and could mark a major shift towards broader access to treatment. While this resolution does not immediately change insurance coverage, many see it as an important step towards reshaping how myopia is viewed, treated, and ultimately reimbursed in the United States. Tony, I imagine you have a position on this. This, especially with Treehouse, you guys are working with docs all the time in practice, and I'm very curious to hear what you think of this article.
So I saw this with great interest. It was amazing. Came out in June, right, with the American Medical Association Assembly passing Resolution 411 or 411, which I thought was interesting, right? Just the number, because it is very informative and will inform, I think, process. Again, I'm a process guy that over many, many years may lead to broad reimbursement. There's a number of different steps in here. I think it's a very, very positive step in myopia. When you think about all the pioneering work that Dr. Kerry Hertzberg has seen, right? I think I remember reading an article or seeing a post, or maybe it was a video of him talking about being in the room when they were talking about myopia and whether it was a disease state or not. And this was in the early part, about 20 years ago. And to think about the journey from there, when it was just orthokeratology and atropine, to where we are product wise and refinements in protocol from all the practitioners worldwide, and especially in this country, to the point where the medical community, the physicians, are backing, declaring this a disease and beginning the advocacy for myopia and myopia management within the entire infrastructure of payers and the federal government and the state governments. That is a very, very big deal. So it's kind of the opening statement there.
Yeah, I'm wondering what this could have, like, impact wise on patient adoption specifically. Andrew, what did you think of this announcement?
Yeah, well, so no question, impactful. The AMA is the elephant in the room for so many conversations and policy decisions and things like that. Um, I have much more mixed feelings in the view that the devil's in the details, and um, I mean, no question, myopia is a disease. We can all agree on that. No question, diseases should be covered under medical insurance. I would presume this is targeting. Um, but my hesitation comes from, where is that money going to come from? And historically, it has not been the case that, medical insurances roll out the red carpet and say, here, we're going to reimburse you a fair amount for this new service.
Immediately.
Right, right. And so, you know, if you tell me that this is going to be an economically viable way for doctors to continue to provide a really high level of care, I think that's fantastic. I'm all on board. If you tell me that, this is going to get kicked to VCPs, for example, I would really be concerned about that. Yeah, they are dragging us down towards lower care. Um, if there is such a small cap on, yearly benefits through whatever insurance that it's practically meaningless, that's a problem. I see an analogy to the scleral world. You know, there are many plans out there, medical plans that will technically cover a scleral fit or technically cover even scleral lenses sometimes, but the reimbursement is less than the provider's cost for those products and services. And that just doesn't work. And so, I guess put me down as skeptical as
Mhm.
for, how this is all going to play out. I think that um, having the AMA and the AOA on the same page on this is huge. And I think that is the glimmer of hope here where, um, maybe we could actually do something really great here that's great for patients, great for doctors, great for everybody. I think it's an important step that had to happen, but I'm really waiting to see how this plays out, and it honestly could end up really good or really bad, I think.
Yeah.
No, I agree. Yeah, the devil is in the details. And as I think about, again, process, right? So this isn't, oh, this is going to be great. I can use Aetna in 3 months and take the child in and get covered and seen, and it's wonderful, right? For a $40 copay because it's a specialist visit. It is going to be a very long journey. There are so many gating mechanisms between here and a future where this is a routine visit to an optometrist. I believe it will stay there for treatment. That skepticism, I think, is very healthy. And there are so many details because, as you brought up, Dr. Brower, um, insurance companies do not make money with full utilization at a fair price, right? That's not their
Yep.
business model. So there will be a lot of foot dragging. There will be a lot of fighting and lobbying and advocacy. And I'm thinking this is a 5 to 10 year slog. But what I'm heartened by is companion legislation still trying to get into committee. And the Myopia Collective talks about it, right? And I think we've talked about it on the show of HR 2527. When you start having these forces correlate together, there will be public policy, I think, that will provide kind of the next generation of care. And if nothing else, greater category education, because I think that's what we're suffering from the most right now.
Right. Yeah, it makes me wonder, like, to what extent is insurance going to cover for myopia? Because the smart docs have learned that their myopia management is a treatment package. It's not just the device, it's not just the drops, it's not just the lenses, it's the entire package. It's what they bring to the table. And I'm wondering how much of that dynamic this is going to play a part of, right? Because I remember the early days of the Ortho K Academy, where the argument was, I hope the Ortho K should never be covered by insurance because we don't want insurance to dictate the level of care that we're going to give, the amount of time we're going to spend with the patient, what lenses we can be fitting. And it makes me wonder, like, how detached from that will be. Like, you have orthokeratology, a lot of it is off-label use, right? So can the doctor then say, well, yes, the portion of this is covered under insurance, but the rest of this for off-label, this off-label lens that I'm going to be making custom for you is not covered under that. So it's a really intriguing process. It definitely, like, it makes me wonder if the old schoolers see this kind of as like that Death Star moment at the beginning of the original Star Wars movie where Alderaan gets destroyed and they're hearing 1,000 voices cry out, right? Because this could seem like a doomsday scenario for that specialty care scenario. But I think the distinction is then around medical insurance and vision insurance. Like, is that a big enough differentiator? Do you think either one of you?
I think it could be, right? Because we all have varying degrees of experience, positive and negative, with both classes of insurance, right? Um, and we don't take insurance at Treehouse. So
Mhm.
we are strictly cash pay and we are global fee. So for the most part, I think that'll be part of it. The other thing to your point, Matthew, with the dictating what is covered and what is cared for, right? It will be evidence based, i.e., FDA cleared. So right now we've only got two. We
Right.
might get three, but I will tell you from experience on the industry side, it is a significant investment and moving goalposts, which we've seen on one indication of what needs to be done, and it's many, many years. And in a corporate world, if you're talking about devices and products, that may never happen, right? So that is devil in the details, to Andrew's point. So
Yeah. Andrew, and as you are in practice, may I ask, like, does your practice take insurance? Is that a part? Like, obviously, your myopia program does not, but like, does the rest of your practice take insurance?
We do participate with medical insurance plans. We do not participate with any VCPs. And
Hmm.
so That was definitely a conscious decision. I think it has to be a conscious decision. No one makes that decision accidentally, because VCPs are the biggest marketing force out there. But I think almost any doc out there will tell you, they're not. Or I'll speak for myself. I am not comfortable with the restrictions they put on. I want to pick the product that's the best for the patient, not the product that is also manufactured by the VCP that provides their coverage. And I think that's an inherent conflict of interest. Certainly, there's one major vision plan that also has a myopia product out there, and I definitely worry about that conflict of interest growing and not shrinking or being checked. And so, to answer your question, medical insurance for us, vision plans, no.
Mhm. Yeah. I mean, one of the reasons why I ask is because the practice I grew up in, we dropped insurance. I remember those days. It was super scary. We saw like 80% of our patients just up and vanish, basically, and would rebuilt from there. And maybe this is the stupid question to ask, but I'm the stupid question guy, so I'll ask it. I mean, couldn't myopia management docs just choose not to incorporate that insurance into their practice? I mean, maybe that's speaking from a privileged position because my dad, the doctor, uh, he had patients come to him from all over the world and they couldn't use insurance regardless of where they were coming from. So they came to him for a very specific reason because he could do what no other optometrists at the time, or very few optometrists, I should say, at the time were doing. So is that a differentiator? Tony, what do you think?
I think you can. I mean, we don't, right? We don't accept insurance. But we did start from scratch, right? So 10 years ago, and we have thousands of patients in treatment, but it is a de novo business, de novo clinics without insurance. To Andrew's point about the marketing machine that VSP or that vision care plans can do for you, it's massive and it is a conscious choice. But once you get the flywheel going and you do all the practice management things that we all know how to do and the audience knows how to do, you can build successful practices. You
Yeah.
can, but it is scary, especially if you are now and then make the choice and drop it like your family did.
Yeah. I I have an episode coming up where I interviewed Dr. Carrie Hartigan, and she's a Treehouse Eyes doc. She says that the way that they do pricing is that, they wanna be able, if atropine isn't working, they wanna be able to move you to something else and not have it be this huge price shift that's like, "Well, this didn't work, so now it's a huge upgrade in price." And there's so much time and energy that goes into taking care of these patients. You have to show up in a way that the average optometrist is just not gonna be able to because of the insurance model, in my opinion. So it makes me wonder, like, how big of an impact this is ultimately going to have. Is there anything that the myopia community can do to kind of curate or help this situation along? Like if the myopia industry were to come together, clinicians, industry, academics, to kind of like help shape what this would look like, what should they be doing? Like what's the next part of that puzzle?
Yeah,
Hmm.
I was thinking about that. I mean, exactly. I was thinking about that, and it comes down, and I'm near Washington D.C., right, physically, um, and and I think it has to come down to advocacy and getting the stakeholders together. Very corporate word, but getting all the stakeholders together that you mentioned to have a singular point of view. That will be incredibly difficult process wise, right? Because everybody has a slightly different view, um, and try to influence the details to allow the clinician and the practitioner at the point of care to make the right decision, right? That's why we do global fee. Exactly what Carrie
Mhm.
told you was so that we can, that the clinicians, the doctors, our doctors that work with us in our own clinics, they can choose whatever they want. In fact, they know the cost of goods. They know that just because they see it. We never talk about it. We never influence it based upon that because we have a fee that allows them to transition up and down the scale, and we expect it. We have the metrics to know about what's going to happen, or about how many times they're going to have to change treatment plan based upon what's happening with
Right.
each individual patient. So.
Yeah. Andrew, anything else to add before we move on to our next topic?
I don't think I do. Tony's insight is fantastic. I I have stuff to process just from listening to what he's saying here. So, no, I'm good.
All right. Okay. Well, then we will move on. Unless, Tony, do you have anything else you want to add?
No, I was just thanking Andrew.
Oh, okay. All right. Let's head to our next topic. I'll read the abstract for this one, and then I will hand it over to you, Andrew, for more in-depth detail. And this is crunchy for me, so bear with me here. I might stumble a little bit, not being an optometrist or clinician myself. So, a new open access study in photodiagnosis and photodynamic therapy, comparing myopia control efficacy and corneal power changes in children wearing corneal refractive therapy and vision shaping treatment orthokeratology lenses with smaller back optic zone diameters. Takes on a question that a lot of us have been circling. When do you shrink the back optic zone? Does the lens diameter still matter? And researchers at Tian Medical University Eye Hospital retrospectively followed 136 eyes of 8 to 11-year-old children with low myopia. Um, this is a fantastic, just very interesting topic. Andrew, what can you tell us more about it?
Yeah. This is the kind of stuff that I eat up. I don't think anybody else cares about this, or most doctors are not on board. But I love you know a personal, I don't know, strength or flaw, depending on how you look at it, is it really eats at me if I don't understand how something works. And so this helps us understand how the myopia control signal works. It does tie together a couple of themes that we hear in other places. Randy Kojima for years has talked about, when you look at the power profile of an ortho K treatment, you want to see a V pattern, not a U pattern. And so that's, in layman's terms, I guess, what a lot of this is saying. We want that steep ramp up and plus within the pupil. Certainly with the different designs, there's some proprietary information that we as clinicians don't have privy to in terms of the exact, curve widths and, things like that. But you can kind of infer from some of these things, if we take this study to be accurate, which again, everything has to be validated, everything has to be, double checked. But if this turns out to be the case, it does kind of point to some design choices that we can intentionally make to improve our treatment effect, which is what everyone's going for. And, I think that it would be a mistake to think that everything is either good or bad. There are positives and negatives to everything, because, this is kind of beating up on CRT a little bit. And, maybe that means that, yes, there are some places where this is not the appropriate product to use. But also there's the flip side of that. And so when you are not creating that big V, that's more an advantage for older uh, kids or adults or whatever. And so, no one parameter is good or bad. No one effect is good or bad. But the more you understand your tools, the more you understand the effect that you can create, the better you can use those to do what you want to do. And so I that to me is, this article is all about that. And I really like that type of thing.
Yeah. Tony, your experience with Cooper Vision and CRT, I'm sure you have a lot to say on this topic. Like, what do you think?
So I would just like to reflect on something that Dr. Brower said, and I think this is the salient point. You understand more about the impact, right? The words that Randy Kojima always said, to get the V instead of the U, is now manifest. Though this is a retrospective study at one site with only 184, all that kind of stuff. It gives insight to the experienced clinician who is facing a problem right now in their chair and is sitting there thinking, what am I going to do? It may not be a product discussion, CRT versus VST. It is more, okay, knowing what I'm seeing in the case that's presenting, knowing that if I steepen that curve, that is going to have an impact. That drives the treatment choice and the follow-on protocol. And I think that is really, really salient here. And I think most of the top tier orthokeratologists are naturally curious about, what does this one thing do? Which lever do I pull to get this treatment effect, given what I'm seeing? When I was with Cooper Vision, we were very proud of the smaller optical zone, right? Because the impact, the science, everything that we'd seen through thousands and thousands of lenses and thousands of patients and reporting back all pointed towards the generally held notion the smaller treatment zone is better, right? This one study, to Andrew's point, just needs to be validated. RCT, I would actually, knowing that it takes a lot of money and a lot of time, this would be something that I would, if I was Bausch, especially vision products, or I was with Paragon, that would be something to invest in to further understand, even if only themselves, like an internal study. It would
Right.
be well worth the time.
Yeah. The TLDR on this whole conversation, which has been ongoing for years, is this insistence that the smaller treatment zone is better by default, as
Mhm.
that's how I've understood it. And I dealt with this when I was with J&J with the Ability lens, because I would get a lot of pushback from docs who would say, "Well, I don't think that this is a small enough treatment zone," or "What about your the BOZD on this?" And it's like, I'm talking to a doctor who's either just starting out or has done ortho-K maybe for 5 years now and is, like, really starting to get cooking. And I feel like this is an argument that is best posed by the advanced designer. So, like, to Andrew's point, if this is something that you wanna dial into, this is important, right? If you're Ken Mahler, if you're Julio Arroyo, if you're Anith Pillay, for instance, to name 3 folks that have been on this podcast, if they tell me that small treatment zone is better, I defer to them because they are designing it through like Wave or iSpace or whatever. Andrew, I know that you design through Wave. I'm interested to hear your perspective on this specifically. I would get pushback from doctors where I like, look, you gave me shitty topographies. We need to fix this problem before we start talking about the small treatment zone. And it's like I kind of put this in perspective. I've got this friend who is a really good photographer. He's a hobbyist, but he studies the pros, the top people in photography. He buys all the equipment that they have, this super expensive equipment. And yet, what do we hear from those photographers? The best camera is the one you have on you when it's time to take the picture, right? So it's like I feel like, this is this ongoing dialogue that we just kind of need to settle. As Andrew, as a Wave design, you use the Wave system, if I'm not mistaken. Like I'm curious to see what your perspective on this is, like as you've grown in expertise and familiarity with lens design.
Yeah. I've personally I've narrowed my designs down to 2 in general. One is Wave, one is a VST design. Um, and gosh, I could take your that was a great little bit there, because I could take that in like 4 different directions. So one thing I would say, so I make this mistake, and you made this mistake like 4 times there. Uh, I think most people make this mistake, but treatment zone is not the same as back optic zone. And so that kind of clarifies, I think if you ask the people that really know and went into designing the CRT 5.0, um, I don't think even they would say that they were expecting a 5 millimeter treatment zone. And even treatment zone has a different definition depending on who you ask. And so a 5.0 back optic zone may not, and probably will not, produce a 5.0 treatment zone, nor should it. And so if you really get picky about semantics, as sometimes you have to do,
Yeah.
I think that clarifies some of what this study was kind of picking at. And I think they almost, in some ways, gratuitously chose their terms a little bit. I think they defined their measurement for treatment zone as um, 3/4 of the way up the plus peak or something like that. And maybe there was a reason, but why did they choose 3/4? Why didn't they choose 100%, or, at the pupil margin, or, pick your number? Um, So yeah, the details matter. There's some of those things that I don't have answers to, but I think that's part of the answer to what difference we're seeing here. One thing I really do like um, is that we have with anything we have leading measures and we have lagging measures, and the lag that we're all caring about is how much did this kid progress over 6 months or a year or whatever. The leading measure, if we actually accept it to be true that power profile shape is more effective, you can tell that almost on day one. You can tell that definitely at day 7 or 30, and so you get a pretty good idea if your treatment is producing the effect that you want, even if you haven't given it time to play out. And so, yes, in Wave, of course, you have wonderful control over almost everything. But also, even with some of these other lab designs, I think are really fantastic. And the better you understand them, the better you can replicate the design features that you're looking for. Um, I really love the complex, but I also have a real admiration for products that can be as simple or as complicated as you want them to be, and they can grow with you. Um, and so, yeah, I like having a variety because I kind of like dealing with all of that stuff.
Yeah. Tony, anything else to add?
No, but I think what's interesting here that Dr. Brower touched upon is actually a commercial principle, right? So if you think about on the industry side, when you would go to market or when we would go to market, I always wanted to have two of everything to present to the ECP because the clinician knows that not every single product can fit every single patient. So you'd want to have, and this is where I like that can grow with you. You wanted to have a couple things in your toolkit to present so that they could choose their own adventure if they needed to. But, talking about the wave design, it can grow with you. Um, Not to be meant as an endorsement, of course, but it is a really good example of something like that, of that principle. Again, I'm a process guy. So yeah, I just wanted to reinforce that.
Yeah. I think this discussion floats the future directions like, Ortho-K combined with corneal cross-linking and the broader cost and compliance burden of overnight wear. Um, you know, Looking past the specific comparison, where do you think Ortho-K design innovation delivers the most real-world benefit next? Like, what do you guys think? Is that in
Can you say that
geometry,
again?
material? Like, looking past the specific comparison, where do you think Ortho-K design innovation delivers the most real-world benefit next? Like, where is innovation going to take us in the future?
Hmm. Well, I mean, just with what you brought up, I love the concept of, locking in your treatment with cross-linking or something similar. That, of course, speaks to, a really old debate about whether there is any stromal change to Ortho-K or whether it's all epithelial. You can cross-link a stroma, you can't cross-link the epithelium, at least with the technology that we have now. Um, And so, yeah, that I mean, if that were ever to come to fruition, that would be marvelous.
Mm,
Um, but but yeah, I think that as a general theme, I've probably said this before, but I think one of the coolest. I don't know if you thought of this, Matt or Carrie, or whose idea this originally was, but just the term or the phrase "vision by design" is like one of the coolest, most intentionally thought out, brilliant short phrases in our industry. Like it, I love being intentional. I love doing things on purpose, and vision by design is like that says it all. Like that's what we
mhm.
want. In terms of what we can manipulate. If we understand everything, we can manipulate everything. If you want better myopia control, we can do it. If you want less glare, we can do that. If you want longer stability, maybe we can do that. Or all of these different things. And so, I don't know if that answered your question at all, but that's kind of how I would think about that.
Yeah.
I'm similar on that. I love bespoke engineering and science. That's what I think orthokeratology is. And and that's a bedrock treatment for myopia management. So I just love it. The when I look across, where is innovation coming from in myopia management and then into orthokeratology? Something that I've been exploring and writing about is there's a lack of investment outside of the industry R&D departments, right? So where are we going to see the next thing? Unless it's a brand new startup like Aurora GP Labs, right? Um, it's really going to stay with the companies that are already out there, other than in what we have today in orthokeratology. There's some other innovations where we get startups, but that's where it's going to live because the money that's coming into myopia management and orthokeratology is in the existing R&D groups.
Right. Yeah. I think that's the crux of my question. Like, when I went through this and started making those kind of notes of things to ask about, it occurred to me that like because this level of design matters to that top tier of ortho K experts like Andrew. So it's like, it's the 80-20 system of like 80% of the cases are going to be done by 20% of the ECPs. Are we going to start to lose ortho K as that extremely relevant, most effective treatment modality for myopia because we're going to have all these other solutions come in? So, what other innovations are going to take place in ortho K if we're moving more towards, anti-myopia spectacles or low dose atropine or even a new medication, which is what we're going to talk about in our fourth story? Like, are we going to start to lose innovation in ortho K? Like, is it just going to stay where it is and only be the purview of a select group of really dynamic and smart fitters?
I
What
don't
do you
think
guys
so.
think? You don't think so?
I don't think so. I think you always have the 80-20 rule in anything
Okay.
that's done, right? There's always that bell curve, right, of adoption and expertise, right? But I think no matter how many more things we add, what I call widgets, no matter how many more widgets we have in the armamentarium, just with the way things are advancing in myopia management, in the regulatory front, and all those other things, and a shift in the culture, it is a viable, well researched, well practiced method of controlling myopia. And what I love about it is what Dr. Breyer was talking about. For those who are really into it, you can control different things to provide different outcomes, to provide the best possible positive outcome for your patient. And that is something that a mass produced pharmaceutical or soft contact lens cannot do. And that's what we have today in orthokeratology. So I think it will always stay as a very big tool in the fight. And you will just have more people are getting exposed to it. I mean, there is in the schools, all the major industry players have very extensive programs to make sure that all the optometric students get exposed to it. So it will perpetuate. But you'll always have the rock stars who will
Right.
always be doing what they do.
Yeah.
I feel like in some ways this brings it full circle back to what we started on, and that Tony, you made a great point about the resolution. The biggest benefit in some ways is just the awareness and getting that message out there. And then with what you just said, Matt, I actually don't think Ortho-K needs to innovate at all for at least the near future and probably the midterm future to continue to be the best option. And one of the things that I've only felt more strongly about over time is that Ortho-K is the best option for most kids most of the time in myopia management. And that's not because I do it. It's actually the opposite of that. The first product I used for that was compounded atropine. A couple years later, VTI's Natural View came along and I started doing that. And then it was a couple years after that that I started doing Ortho-K. And so I've actually come at it from the opposite way. And the more experience I get with all of these things, the more I see the standout advantages of Ortho-K as they exist today. And yes, there will be new products that come along that challenge that and things like that. But as of right now, I think the awareness part of it is the biggest thing. And it's not just awareness of myopia that's struggling. It's the awareness of Ortho-K as the best option if you, in fact, accept that that's true. Now, of course, that's not true for every kid every time, but let's say 80%, I would put the number on. 80% of myopic kids, I think, would be best served with Ortho-K compared to all the other options. And I don't think that's the breakup that we see in the current industry of treatment, and I don't think that's the trend that we're on. I think we are trending away from that, and I think that has some implications with the industry forces and again, all the giant companies that make the various products and things like that want to push us away from that balance that I think is best for the patient. And so, yeah, it's a big, complicated web of a lot of different things, but
Right.
it's certainly fascinating to think about.
Yeah. I'm reminded of, I've got an interview coming out with Dr. David Ng where he talks about a patient that his patients are so much more educated than what he's seen even 2, 3, 5 years ago. He had a patient come in that says, "You do Ortho-K, right?" And he goes, "Yeah, I do Ortho-K. Do you do custom Ortho-K? I want the custom Ortho-K. You do the custom one, right?" And he's like, "Yes, I do the custom Ortho-K." And it makes me wonder how much, to speak about what you were saying about awareness, but both of you said, it makes me wonder how much of the role the patient is going to play in that, where it's like, you see all these stepping stones to, what we think of as the innovator class of myopia management specialists. I've named some of them off in this episode. So maybe that's, to Andrew, to your point, maybe that's where the true innovation is still going to occur, is in where what the doctors are pulling off in their individual lens designs. Like, you'll never believe what I was able to do with this, or with this design, or with this patient. I think that's, if we continue to see innovation, well, it'll definitely have safekeeping in the heart of the advanced designer. I hope I said that correctly.
Well, as much as the individual clinicians, might be a part of that and might be a big part of that, I view Tony as the gateway to that. Treehouse is like the flagship company that it seems like that's the mission,
It is.
and so, if your primary goal is what's best for kids, that will naturally lead into that. And it's almost weird to even say, like, we do what's best for kids is not the primary mission statement of so many other companies in this. And so, yeah, good luck to you, Tony, and everything that you're working on, because, a rising tide lifts all ships here. And that's what we all need.
For sure.
Yeah. And thank you for that. I mean, we are Ortho-K heavy, to your point, Andrew, when you're talking about what's best for children, and the clinicians that work in the treehouse clinics choose orthokeratology more times than not. And they choose different types from different companies. So I found that very interesting, being on the
Yeah.
inside and seeing that, and then just talking to them about it and how they make those choices. But yes, it in the hands of a clinician, I think orthokeratology will remain powerful, Matthew, in the armamentarium, because you can control different pieces and parts. It has excellent efficacy, and it's bespoke. It's bespoke.
Hmm. Yeah, that added level of time and attention with the patient and their parents speaks to that bespoke nature as well. You are getting an experience that the patient is really not going to get at your average optometrist. And, it's like, I'm currently looking for a new general doctor. And it's like, I'm looking into a doctor's office right now where they have a annual fee that is not reimbursed by insurance. And they say, when you talk to them, we have this fee because we want to spend as much time with you as we can. And we need to compensate the office staff and the doctors in order to do that, because insurance isn't going to be a part of that equation. And I love how this sounds. Like, this appeals to me. I work with specialists like this all the time in the optometry. So, like, I really think that that's a huge game changer. It's like, patients and their parents want to feel like they're being taken care of. And custom Ortho-K definitely does that. Even, all levels of Ortho-K does that. All levels of myopia management has the potential to do that. All right. If there's nothing else on that topic, we'll move on to the next one. Um, I will give the overview on this one. I feel like I've talked this one to death, so this is going to be a really quick introduction for me because I'm very curious to hear what your position is on this, Tony. Andrew, you and I have talked about this offline. But Synexus is back in the news again. The FDA is going to convene an advisory committee to review the new drug application for SID 101. It's investigational low dose atropine eye drop for pediatric progressive myopia. The meeting follows the company's appeal after receiving a complete response letter from the FDA in 2025. Despite the phase 3 STAR trial meeting its primary endpoints and the demonstrating significant benefits in its key patient subgroups, while no meeting date has been announced, the advisory committee will review the clinical evidence and could play a pivotal role in determining whether SID 101 becomes the first FDA approved pharmaceutical treatment for progressive myopia in children in the United States. And, just to bring everybody up to speed, if you haven't heard Carrie and I talk about this, we've got numerous episodes and lots of content about it. I am a huge fan of the idea of FDA approved low dose atropine. I think that it's, as Carrie calls it, the Crest toothpaste moment for myopia. And I agree with that. If we have an option that it empowers and enables practitioners who wouldn't have done myopia management or wouldn't even have tried it, I think that this is a very powerful potential move to move them off the sidelines and into the fight and start getting them interested and engaged in myopia management. I thought that, what happened with the FDA's response seemed really suspect. And the more I looked into it, it made less and less sense. I'm not a clinician. So first and foremost, I need to state that. So if there are crunchier details to this, that needs to be observed. And I think everybody has to make up their mind for themselves on this. I think it's awesome that an advisory committee is being convened to re-examine this because I think that's the next logical step to take. It depends on who's on that advisory committee and what exactly they're going to be looking at. But I think that's a very good move. And I think that ultimately this could be a huge win for the FDA, especially aligning with the Surgeon General's spotlight on screen time and how it affects myopia specifically. So I'm curious to hear what y'all have to say. Tony, what is your reaction to this whole thing, going back to the original response letter and up to this point?
So I'm a process guy and I have a sales and marketing background. So I believe individuals matter, right? And I've seen individual decision makers make big changes. And I found it interesting that a complete response letter really wasn't complete, right? So now and you covered this, different parts of the FDA look at different things. And this is the pharma guys and not the med tech guys. The med tech guys have already brought forward, the innovations and indications. So now a totally different group of people, again, people in a bureaucracy. There's change. There's lots of things going on, uproar because the decision-making process was opaque. And now here's a chance for a do-over, right? So to your point about stakeholder roundup, who's going to be on the AdCom and all of this, that is where I'm intensely interested. What would the result be? If we played it forward in a positive and optimistic light, they could get an indication. They're having success in Europe under their CE mark, which is amazing and outstanding. And we'll see what it does for myopia management going, quote unquote, mainstream. I think as having now 3 modalities that could be easy to use, if it gets the indication, could get a lot of the early majority folks. I always think of the bell curve of adoption. They might get on board because they would have the imprimatur of the FDA on it. And now they have yet another thing they could do, and maybe prophylactically. So, and again, I'm not a clinician myself, just an enthusiast. So that's kind of my thought on it. Again, fascinated by the process
Right.
and by the people making the decisions. It's just amazing.
Yeah. Andrew, what do you think?
Yeah, I mean, I think that the foundational part of it we all agree on, and that is, something weird happened there. There, you know, we can't function in a system where the rules change in the middle of the game, and in this one, the rules changed in the middle of the game, and I hope that this is the first step in fixing that and getting it right, and moving towards the outcome that we probably should have gotten before. You know, I as a pure clinician, I really have never been that interested in FDA approval personally. And if anything, it makes my life harder in a lot of cases. Um, I speaking back to the difficulty that it takes to have these studies done and get products approved and things like that. Yeah, I think the public uh, hears FDA approved and they think, oh, this must be the best thing. Maybe, might be. But with again going back to Ortho K, if we take my supposition that Ortho K is the best option for a lot of people, and we also agree that it's never going to be an approved device because of the financial forces, because of the nature of these smaller labs producing the designs compared to these big corporations designed specifically for this, atropine formulation, for example. eh, you know, I think it's a problem, and I don't know what the solution is really, other than, Tony, you made a great point that it kind of boiled down to, well, if you get the patient into your doctor's chair and let them make the decision, I'm great with that. Like, that is going to be a great outcome. But increasingly, um, you know, primary care doctors are going to be prescribing atropine drops. They sure as heck aren't going to be doing Ortho K. They aren't going to be doing contact lenses. They're not going to be doing glasses. Um, Ophthalmology, realistically, 99% of their myopia management is going to be atropine, I would think. There'll be some outliers there,
It already is.
um, but yeah, does the FDA approval say anything towards what is the best option for the patient? No, I don't think it does. And I had a mother just this past week, actually just Monday, I think. We had this discussion and kind of felt like we were butting heads a little bit. That the kid had a wonderful outcome in Ortho K, 2.5 diopters of SIL gone. Control over the last year has been fantastic. Um, and the mom says at the end, well, are we comfortable with this? Do we think that, maybe we should switch to MySight, the FDA approved option? And well, let's talk about this for, a number of reasons. No, I don't think we should do that. I don't think that would be the right choice. Not the least of which is MySight can't correct 2.5 diopters of SIL. But, people hear that FDA approval and think better.
Mhm.
And, I think that, the common theme that keeps coming up is messaging is important. And when you get that one-on-one conversation, you can discuss that. But in the media, in articles, in, honestly, even in, big corporation, corporate optometry, I think there are certain messages about certain approvals and products and things that get steered, maybe not in the best interest of the patient. And so, as with anything, I think this has to move forward with Signexus. I think it should be approved. I think it should have already been approved. But that's not also giving doctors free rein to just say, be lazy and say this is the best option because it's approved either. So we all have to be vigilant in that regard too, and you know continue to make the best choices.
No, that's a very salient point. So on the industry side, we had to undergo training every year, every 6 months, and you had to do this, Matthew. When you had, you had to do your FDA recertification. And what always struck me, again, being a process guy, was, when I was younger, we all read Upton Sinclair's The Jungle, and that's why the FDA came into being, and the whole spiel. But it's safety and efficacy with a big safety piece. And I always think of it as, okay, it's safe. It will not harm you, do no harm, right? In a product with an FDA indication. And that is kind of the education piece for an anxious mother who had that encounter with you, Andrew, right?
Yeah,
At least she asked the question, and your
yeah,
expertise at Gravitas was able to say, no, here's why I made these choices in the best interest of your child, right? And I can explain it to you if you wish. And here we go, right? And come along with me and I'll educate you on that. But yeah, to your point, will it be lazy? There's a lot of doctors. What I fear is there will be doctors in the world who say that they're doing myopia management simply because they have dispensed a thing.
Right.
Yeah.
Right.
That's already happening for sure. Yeah, I've encountered that frequently. I've also encountered the docs who are um, will not touch myopia management without an FDA option. The like I've encountered that before. Why have you never considered OrthoK before? Because there isn't an FDA option. I just don't feel comfortable um, uh, uh, recommending that treatment for my patients. Whereas with like my site, for instance, that was a no brainer for them.
Mhm.
That's what got them involved. That's what got them in the situation. I think both of you are making great points, and that's what life is, right? Like all of these come with benefits and hindrances, and we just have to kind of balance those through the process and hope for the best. What does the advisory committee need to focus on specifically? Do you guys think for the FDA? Like, what do they need to be putting a spotlight on in order to push this forward? What should they be looking at?
Honestly, to me, it's just the credibility of doing what you say you're going to do.
Hmm.
I don't. I'm sure there are more complicated, more nuanced, more scientific things than that, but yeah, eh, my biggest problem is not with any of the science. I mean, I can pick apart, all the different things in the study that I wish were better, wish were different, whatever. But at the end of the day, if you put a target out there and they hit the target, you should stick with your word because I mean, imagine what that's going to do to innovation and spending, if that becomes a trend where
Right.
companies are not confident that even if they hit their target, they're going to get their product approved. That's a disaster for everybody. So to me, that's it. I'm sure Tony has a better answer than that, um, but that's what comes to my mind.
No, that's a huge answer. The other part for me, I think, is um, so again, being the sales and marketing guy and process driven, is how do I provide the opportunity for this huge bureaucracy who has such a big reputation? How do I provide an exit ramp for them so that they can align on this was the goalpost? We hit the goalpost. Here are 3 or 4 things that I wish could be better. Write that up. Signexus will go and address them. Um, and then off you go. And then everybody's can move on, right? Because it when you have an opaque process and you can't explain it, and it was 2 guys ago, the opportunity is here's a chance for a do-over, right?
Hmm.
And how do I do this gracefully so that I don't embarrass the person 2 persons ago, right? Or
Right.
my entire bureaucracy that I'm responsible for
Yeah.
Wonderful
confidence.
point.
That's a great point. Yeah.
There's a there's a little bit of like marriage counseling and a little bit of hostage negotiation in there. Giving that person the off ramp, giving them the grace.
Hmm.
Brilliant as always. Yeah.
Yeah. Well said. All right. Well, if we've nothing else on that one, then we'll close it there and then move to our bonus topic for the paid subscribers. We're going to talk about Thea Life's oral therapy and D10 for myopia. It's incredible. This is not a brand new story. This has been out there, but like I was surprised to see it when review of myopia management highlighted it again, and it is fascinating. And I can't wait to talk about it with you guys. But before we get to the bonus segment, we'll close out the main episode. Tony, we'll start with you. Once again, if anybody wants to reach out to you, has any questions for you, they're interested in Treehouse, how can they get in touch with you online?
Well, I'm always on LinkedIn, so you can find me there, Summer, Sommer. And you can always drop me a line on email at tony.summer, Sommer, at treehouseeyes.com.
Perfect. And Andrew.
Email me at c@icaredupage.com.
Yeah, and this is the part where I sell again once more for the Myopia Mindset Substack. You get the video version of this podcast. You get a weekly newsletter that's being written by Carrie Herzberg, and we're going to start opening that up to other voices real soon across our industry. You'll get a Q&A opportunity. You can send us your questions and gain the benefit of an OrthoK and myopia management expert who's been doing it for 40 plus years. And if you just believe in what we're doing, we think myopia management's the best thing ever. I'm trying to get more ECPs off the sidelines and doing it by sharing the experiences and information. That's the whole point of this podcast and this series of Myopia News Monthly. So if you enjoyed this episode and you want to support us, myopiamindset.substack.com is how you do so. It's just $12 a month, which is basically the cost of a cup of coffee each and every week. And if you would buy Matt Herzberg a cup of coffee to have on amazing guests like Tony and Andrew to talk about the latest topics in myopia management, then please consider becoming a paying subscriber of the Myopia Mindset. Myopiamindset.substack.com is how you do so. Tony, Andrew, thank you so much. Let's move into our bonus segment. And for everybody else, we will see you at the next one.